All right, hello. So today we are talking about crisis. We're going to start with crisis, and you should have an advanced organizer. Did you have any questions about the advanced organizer? Let's start there.
I did have a question for number 7. Um, the priority, is that just determining if there's a need for safety interventions?
Yes. So
Okay,
suicidal, homicidal ideations.
okay. I thought that was it. I just wanted to double check.
That's the priority, and then your other areas are perception of the event,
Yep,
situational support, personal coping.
yep.
Okay, perfect. Any other questions?
I'm good.
We're good? If you're good to move on, just go ahead, shake your head, yes. Okay, great. And I would like to say so far, I've only been through about a third of the case studies, but you guys did really well so far with them. So thank you guys for putting that effort in. I appreciate it. Okay, so we're going to talk about crisis. So crisis by definition is an acute, time-limited occurrence that leaves people struggling to cope, usually 4 to 6 weeks in duration. So it's an acute, time-limited occurrence that leaves people struggling to cope, usually 4 to 6 weeks in duration. The nurse's role is one of the most important things we need to do is monitor our personal feelings so we don't unconsciously prevent people from expressing painful feelings. So there are a lot of painful feelings that go into crisis generally, and if we are not monitoring ourselves, we can block that communication, okay? So for foundations for crisis intervention, there's really 3 different possible resolutions to a crisis. So they can either have a higher level of functioning than what they had before the crisis. They can have the pre-crisis level of functioning or the same level, or they can have a lower level of functioning. So our goal for crisis, so we have to think about crisis as just what we're doing acutely to help that person. And so our goal is the pre-crisis level of functioning, okay? And that's just for crisis intervention. We just want to get them back to where they were before the crisis. Doesn't mean that we're going to stop there, but that would be our crisis resolution. We also need to keep in mind that the nurse may need to take a more active and directive role. Which is in direct contrast to what we usually say. So this gets more into what we would normally do if somebody was, extremely anxious, which they tend to be in crisis. We're more possibly telling them what they need to do instead of giving them lots of choices or, asking them what they want to do. So we want to keep that in mind. At least initially, that's what we would do. Types of crisis. So you looked at these for your advanced organizer: maturational, situational, adventitious. So can somebody give me an example of maturational crisis? Anybody? Example of maturational. Just unmute yourself.
Going to give birth or
Good. Birth, retirement, puberty. Okay. Those are all things that tend to happen to most people at some sort of predictable time frame. What about situational? Somebody else have one for that?
Losing your job.
Absolutely, a job loss. Very good. A divorce, moving, an illness.
Death of a loved one.
Yes, death of a loved one. Yes. Particularly if it's like a non-violent type of death, like more of a, either more of an expected type of death. If we get into adventitious, if it was like a murder, okay, or a terrorist attack or something like that. What would you call what we're all going through right now? This is we're all in crisis mode, right? What would you consider that one?
Situational?
I think you could argue situational or adventitious. And the only reason why I say you could do adventitious, what's your definition of adventitious?
It's unplanned. And
Oh,
something
yeah, unplanned.
It's unplanned. It's not something that most people would experience in their lifetime, right? So I would say you could argue for it to be adventitious, what we're going through right now. So let's talk a little bit about the phases of crisis. So I just want to make sure that these make sense. So initially we're confronted with a conflict and we need to problem solve, and that increases our anxiety, okay? So especially because the problem solving techniques, the defense mechanisms, those start to be stimulated. And what happens is that if those things don't work, what we usually do does not work, we go into phase 2. And so our anxiety level increases to where we're uncomfortable. And then because what we usually do is not working, we get disorganized, we do trial and error type of problem solving where we're just trying things out without really having any idea if they're going to work or not. If that fails, we end up in phase 3. And that's where anxiety can get very high. So it can get to those severe to panic levels, and the person can withdraw or use fight or flight behaviors. If the problem's not resolved and any new types of coping that we try are not effective, then the person can get into phase 4, which is not what we want. This is where the person can be very disorganized, depressed, confused, violent, or suicidal, okay? So we're trying to intervene in those earlier phases of crisis to keep the person from, continuing on. So in the nursing process, the things that we want to make sure that we are assessing. So we want to make sure that we are assessing any religious or cultural beliefs, because that may change how someone is able to effectively deal with a crisis, or some of the techniques that they may choose to use in crisis. So the first major area, though, that we're going to assess is the patient's perception of the precipitating event. So we're going to try to see things through the patient's eyes. This is where our empathy, is very helpful. So some of the questions we might ask are, what was happening in your life before you started to feel this way? What leads you to seek help now? Describe how you are feeling now. How does this situation affect your life? And so we're really trying, again, to understand that person's viewpoint on the situation, because it may be very, very different than what our viewpoint is. The patient's situational support. So just keep in mind that people, depending on what the crisis is, people may go to a different person for different types of crisis. So, and that probably makes sense to you. Each of us probably go to different people for different types of problems or issues. When we're looking for support, advice, help, you don't always go to the same person for everything usually. So we can ask them, who can you trust? Who's available to help you? To whom do you talk when you feel overwhelmed? And then we need to keep in mind that we are the temporary support. Excuse me. That we are the temporary support, especially if nobody else is available. Okay. The third area is the patient's personal coping skills. So we need to assess their level of anxiety and coping mechanisms to see if they are positive or if they're negative coping, and help the patient develop more of the positive coping skills. So we assess for those that are very important. Have you had thoughts of killing yourself or someone else? If yes, have you thought of how you would do that? And of course, you would go into a full suicide or homicide assessment with that. What do you usually do to feel better? What helped you through difficult times in the past? So we're trying to get to what are some of the coping skills that they have used and that have been successful. Nursing diagnoses, things like anxiety, ineffective coping. Ineffective coping works for just about every patient. And then, of course, if the patient was suicidal or homicidal, risk for injury, risk for violence, it just depends on what the patient's symptoms are. So there's lots of different possibilities for that. Outcome, again, we always try to do that with the patient and the family when appropriate and make sure it's realistic. Planning, we do have to remember that initially we may be doing the planning and then including the patient in the planning when they can assist. Implementation number 1 is patient safety. So we may have to use external controls for someone who is suicidal or homicidal. And we need to understand that the patient may not be able to do their usual tasks. So the things that they usually do to keep themselves safe, this could be anything from, watching where they're walking to having actually goal-directed activities, purposeful activities and movement. Depends if the person's in panic level of anxiety, they may not be able to pay attention to anything that's really going on in their environment. So we just want to keep that in mind. This lecture does go a lot hand in hand with that anxiety lecture, okay? And then we need to use anxiety reduction because the patient does have those high levels. So we need to use techniques so that their inner resources can be mobilized. So we're trying to pull out their inner resources. So usually one of the very first things that we can do is just try to get them to focus on us and do some deep breathing exercises. That can try to relieve a little bit of anxiety so that we can hopefully have them pay attention to what it is that we need them to do. Then we want to make sure we're offering support and hope. We are avoiding giving false reassurance. And we role model appropriate behaviors. So we need to make sure we remain calm and in control so that they can see that we are able to do that in these situations. The things that we need to keep in mind, especially after we have some initial anxiety reduction, is that the person is in charge of his or her own life. Once we've made sure they're safe, right? Then they're in charge of their own life. They're able to make decisions once we get that anxiety level down a little bit. And crisis counseling relationship is between partners. So we need to make sure we're including them as much as possible. Levels of nursing care. So you guys remember primary, secondary, tertiary types of care. So a lot of times we look at crisis intervention as being something that is out in the community, although, emergency rooms and any place can really end up doing this type of care, but we think about it a lot in emergency rooms. Primary is the promotion of mental health. reduction of incidence of illness and crisis. So it's basically teaching coping skills so that the person doesn't go into crisis mode to begin with. The secondary are those intervening in acute crisis. So this is definitely your ERs, your clinics, your psychiatric units, where we're working very closely with patients who are right in the middle of having a crisis. So primary is trying to prevent the crisis. Secondary is intervening early in a crisis. And tertiary is that recovery, that support. So things like support groups and community mental health centers. And then the last piece I want to talk about is critical incident stress debriefing. And this is something that is used after a crisis. So I've been part of one of these. This was with a patient who was in restraints. I happen to have him, and I'll tell you that story a little later when we talk about violence and things. But I've taken care of patients in restraints multiple times, but this was a patient that I had in restraints for the longest. He was in restraints for my almost full 12-hour shift, and then much of the next day and a half afterwards. And so if you've never had a patient in 4-point leather restraints from a violent episode, it takes a big toll on you as a person, because you have completely stripped this person of all of their rights. It is something that needs to be debriefed, and that's really what this is a debriefing for the staff. And so we went through the different phases. You don't have to memorize every single phase here, but really kind of understand as a whole what's going on. And so in the introductory phase, we talk about the purpose of the debriefing. So usually a manager, somebody, one of our PCSs is what we call them, our nurse managers, would go through this with us. We talk about the confidentiality and the guidelines for it. The fact phase is the incident is explained and the personal roles are given. So what role did each person have in it? The thought phase is discussing, where everybody discusses their thoughts about the incident. The reaction phase is where they discuss the worst part. So what was the worst part for that person? Sometimes it's different for different people as to what the worst part was. Sometimes it's the same. The symptom phase is discuss any symptoms that the staff might be having. So are they having jumpy feelings where they're kind of like either hypervigilant or easily startled or insomnia? Any of those things would be discussed at that time. The teaching phase, so the manager would go through and normalcy is confirmed. So letting people know that those types of symptoms and things are normal or expected in these situations. And stress management is discussed. So how can the staff, even though they're mental health professionals, it's still helpful to have somebody walk you through this process. And then the re-entry phase. So discussing kind of like closure to the incident, making sure that people are ready to go back and take care of other patients. Or there's referrals that are given. So if somebody is still having difficulties and is not able to go back to work, then this is where those referrals would happen. And that does happen sometimes. I know in this particular incident, this patient was planning attacks on staff, on some of our male staff. It was a male patient. And so some of at least one of the nurses that he attacked did take some time and not go back to the psychiatric intensive care unit for a little while, worked on a different floor for a little bit until he felt better and I think he went through some counseling to feel better to go back to his normal unit, which was the intensive care unit. So evaluations usually 4 to 8 weeks later. And we want to make sure, is the patient still safe? Do they have positive coping, support, and are they at their optimal level of functioning? Any questions about the crisis? No, I'm seeing head shaking no. Make sense? Okay. Do we need a quick break before we go on? Or are we doing okay? Good? Okay, I see some thumbs up. Okay, so the next section then should be page 89, grief and loss. We're all good? Okay. So grief and loss, it kind of goes along with crisis. Unfortunately, everybody has to experience grief and loss in their lifetime. And when we think about losses, though, we want to think about it broad, not just people. Of course, people are one of the things that we think about the most, but also it can be retirement, it can be loss of functioning, it can even be a marriage. It can even be something that you're excited about, but doesn't mean there isn't loss of independence or loss of being single or whatever that may be. Being a parent, right? You may want kids more than anything, but it doesn't mean you don't lose something when you decide to become a parent. So examples of grief would be subjective feelings, an affect precipitated by loss. So some people go through denial when they go through grief. You think about any of the responses that somebody might have. Disenfranchised grief is that grief that can't be openly acknowledged, such as the loss of maybe like a lover. So somebody that you hadn't outright acknowledged a relationship with. Public tragedies are those that are affected, that affect broadly the general public. You could say that we're going through that right now, okay? That we're all going through a loss and having some kind of a grief reaction because we're basically on lockdown. So any sort of national disaster, natural disaster, terrorist attack, anything along those lines would be examples there. So application of the nursing process, we want to assess, so a lot of this again is talking about a person because that's the one that we deal with the most. So assessment, we want to know about their dependence on the deceased. So if somebody loses the person that they're depending on for a lot of care, for emotional support, for finances, that can change how they experience the loss. Did they have unresolved conflict with that person? Because that can change things. Do they have support? How many losses are they experiencing at once? So if you heaven forbid, which I've taken care of a patient who lost like multiple family members in their home in a fire. Okay, that was extremely difficult. I mean, their whole life changed because of that loss. Or stigma. Is there any stigma associated with the loss? So was it a suicide? Was it a homicide? Was it a drug overdose? Was it a loss for, was it a death from AIDS? Any of those things that could be stigmatized. Then the other things we're looking for, are we seeing avoidance? Are we seeing panic? Dissociative, where they're actually disassociating from themselves. So they're, they don't seem to be in touch with reality. Do they have psychosis, suicidal ideations, feelings of being dead, that they can't continue on with life? Are they not going through the mourning process? Or do they have lots of negative images and emotions? They're getting flooded with that. So those are things that we want to look at, and that would help us determine if the person is going through a kind of the normal kind of grief response, or are they going through a more complicated grief. So our nursing diagnoses that we're talking about today is the complicated grief, because we talked about regular grief and fundamentals. So this is patients that are either have complicated grief or are at risk for complicated grief, meaning that they're having difficulty coming to terms with the loss. So it was difficulty coming to terms with the loss. So some things that we would assess for very specifically: do they have guilt about things other than, so other than, make sure those are underlined, actions taken or not taken by the survivor at the time of death. So if they have guilt because they didn't, they feel like they didn't call 911 fast enough, that's normal. Okay. If they feel like they didn't do CPR well enough, that's normal. So it would be looking for guilt about not going to visit the patient over the last several months, not having a fight with them over the phone and not ever resolving it. Stuff like that would be where it would be more likely to be a complicated grief. Do they have thoughts of death other than the survivor feeling that he or she would be better off dead or should have died with the deceased person? Meaning that sometimes, like if somebody survives a car accident or something, they think that if they would have died too, things would be better. That's actually a normal response. Okay. Do they have morbid preoccupation with worthlessness? So are they just constantly having that worthless type feeling? Do they have marked psychomotor retardation? So do they just move really slowly? You could see that. Do they have prolonged and marked functional impairment? So do we expect some functional impairment in anybody going through a major grief episode? Absolutely. But this is where it's more than what you would expect, or it's longer than what you would expect. Maybe they're not bathing, they're not getting out of bed, they're not talking to their children, stuff like that. And then hallucinatory experiences other than thinking that he or she hear the voices of or transiently sees the image of the deceased person. So we need to let patients know that it is actually normal to think that you hear the deceased person's voice, especially shortly after their loss. Now, not them having a whole conversation with you, right? That's an indication of psychosis. But to think that you might hear them saying your name, or you might hear, just their voice on occasion, or think that you see them. Maybe you're in a crowd and you think you see them walking, or walking past a door or something like that. Those things are actually normal. So it's that transient piece where you can't really see a full glimpse of them. You just kind of, see it a little bit. So outcomes, the things that we want to see then, or can the person tolerate intense emotions? Do they have a decreased preoccupation with the deceased person? Do they have periods of stability? So they should continue to get longer periods of stability. Are they taking on previous responsibilities? So are they starting to have those interactions? Are they starting to go back to work or make meals, whatever their responsibilities were? And are they able to start taking on new responsibilities? Can they take on new endeavors? Are they picking up a new hobby? Are they trying to do something new? Do they have positive expectations about the future? So, saying, I think I'm going to be able to get through this. I can tell that things are going to look better, in the future or in the upcoming weeks. And can they remember the positives as well as the negatives of the deceased person? So usually early on in a grief response, people only remember the positive things about the person. So we want them to be able to integrate and have a more realistic view of the person. Implementation, so communication guidelines. We listen actively, so that's important, that we want to make sure that the patient knows that we're listening. And we let the person talk and tell their story, and repeat as necessary. So we let them repeat it with each interaction, but then we try to change the subject, distract the person before they can start it over again. So if you've ever been with someone who worked with a patient who has just lost someone, they tend to tell the story around the death. They tend to tell that story, and they'll tell it once, and then they'll start back over and start telling it again. So we do let them tell it one time with each interaction, but we need to try to stop that cycle so that they're not just saying it over and over again. We need to make sure that we are validating their feelings. Okay? So we say the things that we say are actually a little bit counterintuitive to what you would think, because we're trying to validate how difficult this is for the patient. So we say things like, no one can replace her. His death will be a terrible loss. He'll be missed for a long time. But do you see how that validates what the person might be thinking? And it gives them permission to talk about those intense emotions. Okay, versus some of the things that we usually say that kind of minimize what a person might be feeling. So it's better this way. He's no longer suffering. Even though those are things that we might say to a friend, they kind of minimize. They're not what we want to do in a therapeutic communication, because in a therapeutic communication, we want to open the door for them to discuss these things. And when we say that, well, he's no longer suffering, that kind of closes the door a little bit. It's actually a communication blocker. Does that make sense? One of the things that I usually say, and I say it a lot actually, is this must be very difficult. Or I can't imagine how difficult this must be. Something along those lines. And I kind of use that for lots of different validation, because most of the patients I talk to are having a difficult time. And it just lets them know that I get that this is really difficult for them and that they're doing their best to work through it. Psychotherapy. So somebody may need to go to psychotherapy if for grief, if they are having a complicated grief reaction. So this offers education. It helps them express their emotions. And it can help them create peace with their new relationship with the deceased. And I have used those terms with patients before, used it in group settings, I've used it on one-to-ones, and it is extremely helpful for patients to change their viewpoint when you talk to them and give them permission. Tell them that, one thing that can be helpful going through grief is trying to figure out what your new relationship with that person is going to be. And it gives them permission to think about the fact that they can still have a relationship with that person, that it's not, doesn't have to end right there, that they can still do things on their end. And so, this is anything from setting at Christmas time, setting a chair for the person. This can be, I've known people who have, had a picture and they talked to the picture in the evening of that person. My grandmother did that with my grandfather before she had Alzheimer's disease, as she would go talk to the picture every night and kind of just debrief about her day. And they were married for, 50 years or whatever. And so that was her way of dealing with things. And it worked out for her. So I try to give some examples to patients about how they can include them, but I also just ask, what are ways that this person was included in your day-to-day life, or some of the best memories you had? Is there a way that we can continue that on? Evaluation: have they accepted the reality of the loss? Are they working through the pain and grief? Have they adjusted to an environment in which the person's missing? Have they been able to restructure the family's relationship with the deceased and reinvest in other relationships and life pursuits? I know these are quick. Today they're kind of quick, short, little subjects. But were there any questions about that?
I do have one question, and it kind of goes with addiction, but
Okay.
can a relapse of addiction be started from a complicated grief?
Absolutely.
Okay, that's what I figured. I mean, it makes sense, but
Yeah, and I know family members who started smoking after like they quit.
yeah.
A family member who lost both older, not extremely old actually, probably in their 50s, but lost both brothers in a month and started smoking up after having quit for about a year. Still smoking to this day, and that happened a few years ago. So it's definitely it's a trigger.
Yeah, I was gonna say, because my father, he was sober for 4 years, and we just lost my stepmom last semester, and he's just jumped off the deep end, and I figured that's where that's coming from, and I'm just trying to figure out how to help him. So
It's really difficult. I mean, you have to have somebody who wants the help, and they have to
yeah,
try. I know we have a family member who, when his dad died, especially, worried about him relapsing with alcohol too. And so I personally started calling each day just to see how it was coping and stuff, and seemed to help a little bit. But
yeah,
I knew for sure that was going to be a trigger or a potential trigger. It is
right.
not being, but
Okay,
potential was there. So
cool.
any sort of stressor can be a trigger.
Okay.
Okay. Any other questions? Nope. I'm seeing heads. No. Okay. All right. So the last part for today, as I mentioned, today is a little bit shorter. Schizophrenia. Please plan on being here the whole time, or possibly going over just a few minutes, just because it is more difficult information. Okay. So handout over older adults should be your next page. Page 90. Okay. So psychiatric disorders in older adults are actually more likely to get inadequate or inappropriate treatment compared to younger adults. Sometimes it's more difficult to recognize what's going on with our older adults. So unfortunately, they don't get the treatment that they need and deserve. So for depression, only about half of older adults are identified as actually having depression. So only half of those with depression are identified as having depression. So we're missing half of them. And we need to understand that depression is not a normal part of aging. It's something that needs to be treated. We also want to try to prevent it. That's our priority, is to try to prevent depression from happening in our older adult population. So some of the symptoms that we can see. So these are in addition to what we see in depression in our younger population, in our, young adults and kind of middle-aged adults. So they can have more memory loss, even some intellect impairment. They can be asocial or agitated, do tend to see insomnia more, loss of appetite, increased concern with bodily behaviors. I mean, how often have you heard some older adults, in fact, that's generally a conception that people have about older adults being more concerned with what's going on with their body, bowels, all that stuff. And that could actually be a potential sign of a depression. So we want to keep that in mind. Apprehension and anxiety without any trigger. So those are important to think about. Now, antidepressant therapy starts low and goes slow. So that's really important in this population. Not that it's not important in most populations, but really need to make sure that the dosages are really low. SSRIs tend to have less side effects and less toxicity. So Zoloft or sertraline is generally the drug of choice. However, so that was sertraline or Zoloft. However, TCAs, so tricyclic antidepressants, TCAs are recommended for those with osteoporosis, who are frail, who fall a lot, anything along those lines. Okay, so that was TCAs for anybody who's frail, falls, osteoporosis, anybody who's kind of at higher risk for breaking bones and stuff like that. Psychotherapy, so groups usually help with creative ways to lift mood, improve quality of life. So groups are really great in our older population. And at the end here, we'll talk about reminiscence therapy, which is one of my favorite types of groups to do with older patients. Our suicide, they do tend to have higher levels of completion because they usually choose more lethal means. So we do need to understand that if our older adults are contemplating or talking about suicide, that their completion rates are higher. Assessment, we look for things like hopelessness, uselessness, despair. And this can be a final gesture of control. So they can view suicide, maybe they don't have a lot of choices in their life, maybe they feel like they don't get to do the things that they want to do anymore. And so they could, in fact, use this as a way to kind of have that gesture of control. We watch for it more in those with severe medical illnesses, functional disability, alcohol abuse, suicide attempts, anxiety, psychotic depression, those with lots of losses that are happening all at once, widowhood, and intractable pain. So intractable pain means it's not responding to pain interventions. We want to watch, these are usually not a cry for help. So if somebody has suicidal behaviors or parasuicidal behaviors, this is not usually a cry for help, but an actual desire to die. Okay, an actual desire to die. We also want to be very respectful and sensitive when interviewing this population, when talking to them about suicide or even about depression. We're still where a lot of our older adults, mental illness was not something that was discussed. So a lot of times they may not be comfortable discussing it, especially if, they haven't had a lot of experience with having depression in the past. So, or haven't really had treatment for depression in the past. And this is something newer since they've been older. I've had people that just have a really difficult time talking about depression or even admitting to the fact that that's what they have. So next we talk about alcoholism and substance abuse in our older adults. This is really an interesting topic area, and I very much look forward to when they start talking about older adults and things like opiate abuse. There's not a lot of information on older adults and substance abuse out there yet, but I think there will be very soon because we are having populations that use drugs earlier in life are starting to get to be older adults. And so we are seeing more drug use in older adults. So primarily here, we're going to talk about alcoholism. So alcoholism in older adults is often seen with retirement, widowhood, or loneliness. The things that we have to watch for, especially in this population, so this doesn't take place of all the things we already talked about, but more in addition, what we want to pay attention to: malnutrition, self-neglect, impaired cognition, depression, and falls. Falls are really big. I cannot tell you how many patients, older adults, that came in because they were intoxicated and fell. And just bruised up faces, hitting their face on concrete, stairs, all kinds of stuff, black and blue, because they fell. So there's kind of two ways that people kind of get categorized. or that the illness is categorized. One is the aging alcoholic, and the other one is a geriatric problem drinker. So the aging alcoholic is just what it sounds like. It's somebody who has had an alcohol use disorder throughout their life, and they just have gotten older. Okay. So they've used this as their primary way of coping since they were, young. And they've just continued on since they're older. The prognosis, as you can imagine, the prognosis for this, well, what do you think? Do you think the prognosis is good or poor?
Poor.
Poor. Yeah, this is somebody who has continued to use the same thing throughout their life. So the prognosis, how often do we change those things that have been ingrained in us for years and years and years? Okay, so the prognosis is poor. A geriatric problem drinker, however, is somebody who does not have a history of alcohol problems, but does develop a pattern in response to the stressors of aging. So they're lonely, they've now become a widow or widower, and they're retired, they don't have a lot going on anymore, and so they start drinking. So the prognosis for that is actually pretty good. Yeah, because they haven't been doing this long term. This is more of a short term type of coping mechanism, and so we can try to help them work through that. Treatments. So we look at social therapies, interpersonal therapies with professionals, things like AA, so support groups are really helpful. And we want to ensure that we educate them on available resources, and maybe we can find an AA group that's more for older adults. Or maybe it's gender specific, something like that would help make the person more comfortable. Substance abuse, as I mentioned, there's not a whole lot of data on misuse of prescriptions or even over-the-counter medications in this group, but that will change here in the next few years, I believe. So the last thing we're going to mention today is the reminiscence therapy. So this is one of my favorite things. And again, I don't do therapy, but I've done reminiscence groups that take pieces of this. So reminiscence therapy would be where, they do this on a regular basis. It's thinking about past and reflecting on it. It helps with self-esteem, helps decrease depression. They discuss past events with their peers, like specific life transitions. But what's really important is that they have to talk about both the positive and the negative aspects of those life transitions. So if that was retirement, marriage, divorce, having kids leave the house, whatever it is, there's usually positive and negatives associated with each thing. And so we want them to be able to discuss both of those aspects. And then we help them work through those negative aspects. So usually, they have to be able to work through those problems and accept them. So even the negative aspects of it, they have to accept the resolution and for it to be a positive experience overall. And so that would mean if I went through, let's say I'm not going through a divorce, but let's say if I was going through a divorce, I would think about the negative parts. It would impact my daughter. It would mean that I have less support at home, but maybe the positive parts is maybe now I'm away from a very negative person or somebody who wasn't supportive, and I can think about the resolution of it is in the end, this was, even though it was a really difficult transition and time frame in my life, I can look back on it and say that I grew from it. I learned how to be more independent, things like that. So it's being able to kind of look back on things and work through the negative aspects. They can use photos, music, special foods, anything like that to stimulate discussion. So when I've done a group like this, where it's just a one-time group, psychoeducational group on the geriatric unit, I've had patients, they could bring either a song lyrics or a poem, and I helped them look some stuff up, printed some things off for them, a picture if they had it, anything along the line, something that made them feel or that triggered a feeling of peacefulness and contentment when they were a child. And so it was so awesome because you have these patients who you think don't really have good memories and stuff, and they're reciting poetry and singing songs in this group. So some of them I didn't have to look anything up, they just knew. And I mean that people were literally reciting poetry to me, you know, they're in their 80s, and I thought that they didn't have a very good memory, and then they're telling me this stuff. And they would it gives me chills, actually have chills right now. But and they would talk about, you know, a time when they felt most content, or they would share a picture. And what I did is they bring up that feeling of that contentment, and I asked them to kind of share how they feel, and they would talk about being relaxed and talk about the warm sunshine, you know, whatever it is. And then we talked about ways to draw on that as a coping mechanism when they're feeling anxious or sad, depressed, alone, you know, any of those things. Can they bring that feeling back up and help themselves feel a little bit better? Or call one of us and we'll talk to them about it and bring that feeling back up. And they loved it. And so I did that group several times at, you know, at different time points while I worked with the geriatric population. But if you ever have a chance to work with the older adults, it's a really good way to help them. Are there any questions?
No.
No. And does it make sense that that would help them through their last stage of Erickson's too? To kind of work through things and have a positive outlook on their life and stuff instead of despair?
Yeah.
So that's what we're doing is if you think about it, is we're really helping them finish Erickson's. All right. Well, that is all for today. And I'm going to stop recording.